Another thing what I have personally realized is poor IV line care or infusion management. I just discussed a lot of about infusion management. Poor IV line care, because we do follow the VIP score or the visual infusion phlebitis score bundle, but most of the time the site of cannulation is little awkward. Sometimes you are using the back of the arm where patient is not able to keep it on the bed. Patient is having difficulty in mobility. Sometimes placing an EJV also makes mobility restricted. Utilizing cannula on lower limb can also lead to a lot of problems. There could be accidental removal of cannula, accidental edema can be there. There could be a lot of edema with lower limb cannulation, increased incidence of DVT with lower limb cannulation. So usually we avoid lower limb cannulation. We avoid two extremes cannulation sites. We preferably use a 20 gauge, 16 gauge or 18 gauge cannula in all adult patients. We don't use a bigger vein. Do take care of the IV lines, avoid infection, use gloves and hand hygiene practices while handling the IV lines. As a nurse, we must look at the early warning signs. We must raise the trigger or alarms if you are seeing any subtle changes in patient's clinical condition, let it be hemodynamics, let it be sensorium. So try to notify early, because early notification can help us to do the right thing at the right place, and actually it can improve the outcomes. Improper ventilator handling is also one area, because most of the times a staff is not very much acquainted to learn about the ventilator alarms. So as a nurse, I do expect each and every nurse to be more familiar with the ventilator or the availability of what kind of ventilator is there in your ICU. What are the common alarms in ventilator? Every time a staff is not supposed to just make that alarm silent, because that alarm is due to some reason. So either inform the doctor, and as nursing staff in critical care can be more smart to detect and correct these alarms. Sometimes the alarm could be because of higher rise in pressures. Sometimes there could be too much of secretions. Sometimes inadequate tidal volume generations. Sometimes inadequate effort. Sometimes too much of asynchrony. Patient is fighting on the ventilator. So small things. I expect a good staff handling critical care patients should be more familiar about the ventilator, more familiar about the settings of the ventilator, backup ventilation, and timely intimation to the doctors to take care of the increasing demand of the ventilator or increasing demand of the oxygen or the compliance of the patient. So every staff must undergo some amount of training to handle these patients on NIV, invasive ventilation, HFNC, or even small BiPAP. And even we should be more familiar with handling patients on tracheostomy support as well as with invasive ventilation. And believe me, and every nurse, with the more and more advancements with NIV, the use of NIV has also tremendously increased. So every nurse should be more familiar with handling NIV patients, how much leak should be tolerable, how much patient is able to generate tidal volume, how much difficulty patient is going through, avoidance of pressure area over the nose. So these are some common things which a good nurse can avoid in their intensive care practices to improve the patient satisfaction as well as the overall survival of these patients. Poor infection control of invasive devices. What could be the invasive devices? One is endotracheal tube or the tracheostomy tube, Ryle's tube, Foley's catheterization, central line, dialysis catheter, temporary pacemaker, lines. So these are all invasive devices which needs, or drains, ICD. So all these devices needs a proper care and handling to avoid infections. A special note about the ICD, because ICD requires an emphasis on better care of ICD. Their drain bag should be open to environment. There should be minimal water level to be maintained. Every time the bag should not be above the level of the chest. We must monitor there daily the ICD site as well as the bubbling in the ICD column. Any inadvertent removal of ICD has to be notified immediately. Any pull-up of central line has to be notified. Any new problems with any invasive catheters or lines has to be notified, because this is what a nurse is actually more towards the bedside, more time standing next to the bedside. So small changes, small efforts, small bundles can actually improve the outcome. And this is what I personally feel most of you are doing, but this is one mistake where we can always improve on, because we have seen incidences of pneumothorax or misadventures with ICD, sudden extubation, self extubation, tracheostomy pull out. So these are common things which we can look at. In case if you feel there is a risk of self extubation, we can also consider restraint in sync with the family and documentation of the same facts.